Good morning. So I was asked to talk a little bit this morning about the quantification of mitral regurgitation, and I thought I probably wouldn't. I wanted to talk a little bit about the issues with mitral anatomy that face everyone who is trying to develop a new device in their own garage. And I think that basically, after I show you my disclosures, we should think about how we got here. Well, for us, it's 1923 again. Right, Elliot Cutler at the Brigham was the first person to operate on this young patient, 11 years old, with very severe rheumatic mitral stenosis, and she was the first person to actually survive that operation. The then Boston Medical Journal and now New England Journal published the article that outlined this case report, and Cutler went on to say, at this stage of our observations, we cannot with accuracy define what has occurred, nor what benefits may have accrued, if any, sound familiar with our current state of percutaneous mitral interventions. It goes on to say that it does show that surgical intervention in cases of mitral stenosis bears no special risk. Well, that was a bit optimistic. And then he went on to say that technical improvements that should render a subsequent attempt both less hazardous as well as more hopeful for success. And this is true today with percutaneous mitral technology. And so we have to think about the two types of mitral regurgitation. As you know, there's degenerative mitral regurgitation and functional mitral regurgitation, and we've often separated the two. But interestingly, you have to also recognize that mitral regurgitation creates mitral regurgitation because of its effects on the ventricle and the rest of the mitral apparatus. Degenerative mitral regurgitation is common, but less common than functional MR, of which there are about 5 million cases worldwide. And there are several phases of mitral regurgitation, and our surgical colleagues have well taught us this. There are patients that are asymptomatic and normal. They have a compensated ventricle, no secondary anatomic abnormalities, nothing that can be measured wrong on their echocardiogram except for their mitral regurgitation. And they have absolutely normal exercise performance if you were to test them with cardiopulmonary exercise testing. Then there's a large number of patients that are asymptomatic but compensated. They have some secondary consequence of their mitral regurgitation. Their atrium is a little large, the ventricle is a little large and poopy, and if they're tested, they really do have some functional limitation on cardiopulmonary exercise testing. And then the patient comes to you who is mildly symptomatic. Well, I can't do what I used to do. I used to hike at altitude and I get tachycardic and don't feel so good. But those patients may have an irreversible prognosis. They've already had damage done to their cardiac system, and this may or may not be reparable with repair of the mitral regurgitation. And then we go on to the symptomatic patient who is very symptomatic and everybody agrees needs treatment.